Welcome to this comprehensive overview of dyslipidemia. Updated with the latest 2025 guidelines from the European Society of Cardiology and the European Atherosclerosis Society. Cardiovascular disease remains the leading cause of mortality globally, and dyslipidemia is one of its most significant, yet modifiable, risk factors. At its core, dyslipidemia involves abnormal levels of lipids in the blood. The primary culprit in atherosclerosis is low-density lipoprotein, or LDL cholesterol, when LDL particles penetrate the arterial wall. They become oxidized and trigger an inflammatory cascade. Macrophages engulf these particles, transforming into foam cells. Over time, this accumulation forms atherosclerotic plaques, narrowing the arteries and setting the stage for heart attacks and strokes. The 2025 ESC guidelines emphasize a highly personalized, risk-based approach to lipid management. The cornerstone of this strategy is accurate risk prediction. The guidelines strongly recommend using the SCORE2 algorithm for individuals aged 40 to 69, and the SCORE2OP algorithm for older persons aged 70 to 89. Unlike previous tools, SCORE2 estimates the 10-year risk of both fatal and non-fatal cardiovascular events, utilizing non-HDL cholesterol for greater accuracy. Based on this assessment, patients are stratified into risk categories, which dictate their specific LDL cholesterol targets. The principle is clear. The higher the cardiovascular risk, the lower the LDL target must be. For moderate risk patients, the target is below 100 mg per deciliter. High-risk patients should aim below 70 mg per deciliter. Very high-risk patients must achieve below 55 mg per deciliter. And for extreme risk patients, those with recurrent events despite maximum therapy, the target is an aggressive below 40 mg per deciliter. A major highlight of the 2025 update is the elevated focus on lipoprotein A, or LP. LP is an LDL-like particle with an added apolipoprotein attached. It is highly atherogenic and prothrombotic. Crucially, LP levels are predominantly genetically determined and remain relatively stable throughout a person's life. The new guidelines recommend that LP should be measured at least once in every adult's lifetime. A level of 50 mg per deciliter or higher is considered a significant risk-enhancing factor, which may justify reclassifying a patient into a higher risk category and intensifying their therapy. When lifestyle modifications, such as a Mediterranean diet and regular exercise, are insufficient, pharmacological intervention is required. The foundation of lipid-lowering therapy remains high-intensity statins, which inhibit cholesterol synthesis in the liver and upregulate LDL receptors, clearing cholesterol from the blood. However, the 2025 guidelines strongly endorse early combination therapy to reach ambitious targets. If statins alone are not enough, ezetimibe is added to inhibit intestinal cholesterol absorption. For patients still not at goal, PCSK9 inhibitors can be introduced, leading to an unprecedented LDL reduction of up to 86%. The 2025 update formally integrates new therapies into the treatment algorithm. Bempedoic acid, a novel oral medication that works upstream of statins, is now recommended, particularly for patients who are statin intolerant. Additionally, evinacumab, a monoclonal antibody, is recommended for patients with homozygous familial hypercholesterolemia, as it effectively lowers LDL, even in the absence of functional LDL receptors. For patients hospitalized with an acute coronary syndrome, the guidelines advocate a paradigm shift, rather than a slow, stepwise approach. Immediate initiation of combination therapy, specifically a high-intensity statin plus ezetimibe, is recommended during the index hospitalization to rapidly stabilize plaques and prevent recurrent events. The 2025 guidelines also expand protection to highly vulnerable populations. Based on recent trials, statin therapy is now recommended for primary prevention in people living with HIV aged 40 and older, regardless of their calculated cardiovascular risk. Furthermore, statins are recommended for cancer patients undergoing therapies associated with high cardiovascular toxicity, such as anthracyclines. Finally, the guidelines deliver a definitive stance on dietary supplements. Following rigorous review, the ESC concludes there is no evidence that supplements or vitamins, including fish oil, garlic, or turmeric, are both safe and effective for lowering LDL cholesterol or preventing cardiovascular disease. The guidelines explicitly do not recommend their use for this purpose, emphasizing the superiority of proven pharmacological therapies. In summary, the 2025 ESC and EAS guidelines champion a proactive, personalized, and aggressive approach to dyslipidemia by utilizing advanced risk prediction with SCORE2, measuring lipoproteinol, and embracing early combination therapies including novel agents. We can dramatically reduce the global burden of cardiovascular disease. Thank you for watching. Please subscribe for more medical updates and detailed clinical reviews.